Today we'll be talking about concavity compression. This is a form of articular stabilization, and it's particularly emphasized in the shoulder, the glenohumeral joint, although the model works for all joints. It's just that some joints require it more than others, and the shoulder is one that requires it. The reason is that the shoulder is inherently unstable. The joint surfaces are not particularly congruent, we'll talk about in a second. The joint capsule is lax. The ligaments are not particularly strong. All in all, this is to provide it with the high degree of mobility you need in your daily life. Now, if we look at these one factor at a time, the joint congruency of the articular surfaces is not very great. The radial head has a radius that's much smaller than that of the glenoid fossa, which means that in relative terms, the humeral head is a ball and the fossa is a plane surface. Rather than call this a ball and socket joint, it should probably be called a ball and table joint. But the fossa is augmented by the labrum, and this deepens the fossa as well as affording ligamentous attachments, but it deepens the fossa and it extends the fossa. So it reduces the size of the radius of the glenoid. And so it makes this fit much better, the fit between the humeral head and the glenoid. It's an important factor. The more congruent the surfaces, the more control there is of the joint surfaces. Also, a high degree of congruency will reduce the amount of air within between the surfaces, and the pressure will drop if you're in a sealed environment. And the capsule produces that sealed environment. So between the joint surfaces, there is a gradient between its pressure and certainly the pressure within the joint itself, but also between the intra-articular pressure and the body's pressure on the outside of this. So it means that with this reduced pressure, this pressure gradient, basically between the two surfaces, then between the articular volume and the outside of the body, these two surfaces are, if you like, sucked together. They're actually blown together, but if you think about these two things sucking together, that's fine. That is also going to improve the stability on this. So that's the concavity aspect of this. The compression part of this is provided by muscle activity. And these are mostly shunt muscles that will do this. And these are muscles that are orientated in such a way that their contraction will basically act along the shaft or the neck of the bone, that is along the mechanical axis of the bone, and push these joints together, which we'll see in a second. So this provides a compression component. Now, the shoulder, as I say, has incongruency, a very small labrum producing that congruency, so it doesn't take much to destroy this labrum. It's only a couple of millimeters thick and high. It's not very big at all. So, and the capsule is lax because it's got to be to allow the movements, and the ligaments are not the strongest ligaments in the body. So one way or another, this is very dependent on this concavity compression model. Okay, so we'll look at each component of this individually and see if we can make sense of it. All right, then first let's look at the joint surfaces. As we said, basically the surface area on the humeral head is much, much larger than the surface area on the glenoid, about 5:1, I understand. There's a law, basically, that says that the bigger the discrepancies between joint partner surfaces, the greater is the potential for movement, all else being equal. This would give the shoulder a hell of a lot of movement there, and of course, the shoulder has a hell of a lot of movement. But this also means that it's not particularly stable. This is not helped by the fact that the joint surfaces are not particularly congruent. The radius of the humeral head is much smaller than the radius of the glenoid fossa, which means that there's no good fit there. They don't fit together very well. And the small diagram of the red ball and the blue surface shows that the glenoid is much flatter than the humeral head. So there's no congruency there, but this is helped by the labrum. As small as it is, this will direct the attachment of the capsule ligaments forwards over the joint. So it makes the whole thing more congruent. It brings it all together. It brings the capsule in. As lax as the capsule is, its direction is out from the joint surface rather than it's radiating outwards, as it might well do from the bone. So it increases the congruency, but at the same time, the fact that the labrum is flexible, it stops the effect of the two surfaces being more equal in size. By being deformable, it allows the movement there, but at the same time increases the congruency. So it does two jobs at once. Otherwise, the shoulder would look a bit like the hip as far as range of motion, so which is still a lot, but it's nowhere near what the shoulder has. So these are the surfaces, and as I said, basically, because they're very congruent, it means that when they fit together, there isn't much room between them for much else, including fluids and gases. So this will form a partial vacuum between the two surfaces, providing the joint surfaces are within a sealed environment. And this, as we'll see, is what we get in the shoulder. These diagrams of how the capsule relates to the joint really do show how concave that area is. Remember that the capsule, while lax, is nonetheless the seal of this joint. And that enclosure there allows that negative pressure between the articular surfaces, because of their congruency, to be maintained. And you can see the role of the labrum in this diagram as well. It's quite an arrangement, much more so than you might think, and it gives you a different perspective on what the capsule actually does. While it is a limiter of end range movement, it also is involved, as lax as it is still involved in the mid-range movements of the joint and the stabilization of the joint within those ranges. Certainly different to the emphasis you may have seen before on this joint, but it plays a big role in this concavity compression scenario. These diagrams depict the directions of force acting between the humeral head and the glenoid. You can see that most of these will shunt the humeral head into the fossa. The one that doesn't conform to this idea is the vertical force generated by the long-headed biceps. It's probably not its function to do this at all, unless the arm's out to the side. There has been this cadaveric research done where they've cut the biceps tendon and found that it's 2.5 to 3 times more easy to dislocate the shoulder with the tendon cut than without it cut. So even in a dead body, the tendon is helping to stabilize the joint, and this is almost certainly its function as far as stability is concerned around the shoulder. But the rest of them all act through the neck of the humerus, shunt the two bones together and help stabilize the joints. This is the compression part of concavity compression. Even when the joint's at rest, the tone will be helping to do that. So that when you lift your arm out from the side, then the rotator cuff basically is going to contract more or less at the same time, shunt these bones together, so it spins, it skids on the surface rather than translate up or down. And you can see why when you do it passively, it will translate, because these muscles are no longer doing that to a sufficient degree. It's worth noting that when these muscles are weak, which you see with things like reflex inhibition, segmental facilitation, injury to the muscle, then the labrum can become degenerated. And this is almost certainly because that muscle isn't controlling the translation in a particular direction, and it just beats at the glenoid until it degenerates. So providing these muscles are contracting and there is a net zero force, a net resultant force, other than the one jamming it into the fossa, and not anterior, posterior, upwards and downwards, but just into the fossa, then there's no reason for the labrum to become degenerate under these circumstances and from this cause. So this is the compression part of concavity compression. And here are the muscles that do the compression. The rotator cuff, supraspinatus, infraspinatus, teres minor, and subscapularis. All of these will pull along a line that will jam the humeral head into the fossa. What you can see from the back is teres major. Now, this is the attachment of this is further down the humerus. So it's unlikely that this is playing much of a role in compressing that. In fact, it's quite possible it's doing the exact opposite and trying to distract the joint surfaces as it levers itself away from it. But it's not going to play a big role in the compression component of concavity compression model. This is the main function of the rotator cuff, is to stabilize the shoulder. These are true shunt muscles. They've got every attribute of shunt muscles, and they work really quite well at this. They must be rehabilitated when necessary. Otherwise, there's no reason not to expect the same thing to happen again and again. And of course, the more often it happens, the more reflex inhibition you get, the more nociception you get, the more segmental facilitation you get. Therefore, the weaker these muscles get, and so you lose stabilization on the shoulder, and the thing gets worse and worse and worse. It's a negative feedback loop. You have to cut it somewhere if you possibly can. Anyway, that's the presentation. I hope you enjoyed it. Gave you some insight into the stability of the glenohumeral joint, and I'll be talking to you again soon. Bye.